from Egypt, Saudi Arabia, and different Arab countries. We are especially delighted to welcome our colleagues joining us from the International Association of Dental Students, Saudi Arabia, and Egypt, including participants from Al Qasr Al Aini, Ain Shams, and Tanta University, in addition to colleagues from other Arab countries. A warm welcome as well to our colleagues from universities across Sudan, in addition to our colleagues in the University of Khartoum. We warmly welcome you all to the first day of this two-day webinar. Today's session will focus on orthodontics under the title Mastering Orthognathic Surgery. We sincerely hope you find it both insightful and enriching. Now, it's our pleasure to introduce our distinguished speaker, Dr. Gamar Ahmed Suleiman. Dr. Gamar is an assistant professor and senior consultant of orthodontics and dentofacial orthopedics at the Faculty of Dentistry, University of Khartoum. He also serves as an international examiner for the membership of the Faculty of Dentistry of the Royal College of Surgeons in Ireland, MFD RCSI, and the Fellowship of the Faculty of Dentistry of the Royal College of Surgeons in Ireland in Orthodontics, FFD-RCSI. He is also the head of the Division of Orthodontics and the clinical director at the Faculty of Dentistry, University of Khartoum. He holds a baccalaureate of dental surgery and a clinical master's degree in orthodontics and dentofacial orthopedics from the University of Khartoum. Dr. Gamer is a member of the Faculty of Dentistry at the Royal College of Surgeons in Ireland, MFD-RCSI, and a member of the Faculty of Dental Surgery at the Royal College of Physicians and Surgeons at United Kingdom, MFD-SRCBS UK. He is also a fellow of the Faculty of Dentistry at the Royal College of Surgeons in Ireland, FFD-RCSI, and a fellow of the Faculty of Dental Surgery at the Royal College of Physicians and Surgeons at United Kingdom, FDS-RCBS UK. In addition, he holds a higher diploma in research methodology and biostatics from University of Medical Science and Technology. Please join us in warmly welcoming Dr. Gamer.
Assalamu alaikum. Thank you, Kaya. Thank you for your nice presentation. And thank you for our colleagues from overall the world, as well as from Faculty of Dentistry, University of Khartoum, and our future colleagues, Faculty of Dentistry, University of Khartoum student, and other Sudan dental student members, as well as in Arabs, as well as IATS, International Association of Dental Students, joining us from Egypt, from Saudi Arabia, from Yemen, from a lot of Arab countries. And thank you, our professors, my teachers at University of Khartoum, my teacher at the Royal College of Surgeons, all my teachers in the Faculty of Dentistry, as well as in my department. So we're going today to share our knowledge together in orthodontic surgery, and we're going to concentrate on the orthodontics perspective for this topic. So now we can start. Also, I'm going to extend my Thanks for my colleagues in Saudi Arabia, consultants, and doctors, and in Yemen, and the Sudanese Orthodontic Society. So now we are going to start our topic, which is mastering orthodontic surgery, uh, prospective orthodontics view. In simple definition, orthodontic surgery is a correction of skeletal discrepancy that, due to their severity, lie outside the scope of orthodontics alone, usually deferred until active growth has slowed to adult level. So whenever we have so severe cases, moderate to severe cases, that lie outside the scope of orthodontics, we are going to carry out some sort of orthodontic surgery for them. And orthodontic, just moving these and the alveolar bone around. Orthodontic, it will never move the basal bone for the maxilla or the mandible or both. So let us discuss some sort of procedure that can be carried out together as a team. Secretary procedures, anterior posterior direction. Regarding the maxillary borogonism, we have which we call it subapical osteotomy and Lefort 1 osteotomy. If we have retrogressive maxilla, we have to have Lefort 1 osteotomy to advance or to retract the maxilla for progressive maxilla. Lefort 2 and Lefort 3 osteotomy if you have Lefort 2 fracture and Lefort 3 fracture. And this is described by Lefort's 1956. Regarding the mandibular surgery, bilateral sagittal split osteotomy, which is described by Geezer, 1965. Mandibular borogonism, we can carry out bilateral sagittal split osteotomy or extraoral vertical osteotomy or reduction genioplasty. Also, it will help in reducing the borogonistic mandible. If we have retrogressive mandible, we are going to carry out bilateral sagittal split osteotomy. Bilateral sagittal split osteotomy you can carry it out for borogonistic mandible or retrogressive mandible. So for advancement or taking back the mandible. Intraoral vertical osteotomy or augmentation osteotomy. And this is for the, if you're going to carry out something for the chin, we're going to do some sort of sliding genioplasty, which is very stable. Regarding the transverse vertical and vertical problems, we can carry out for transverse mid-palatal osteotomy. Mid-palatal osteotomy, we can do it by a lot of mechanics. One of them is SARB, sagittal split palatal expansion. Or we can do it by, nowadays, we used to do some sort of marping, which is rapid palatal expansion by TAG, by temporary anchoring devices. So we carry out some sort of device, which we call it marping, or rapid palatal expansion without surgery. We do some sort of mini screw on the expander to separate the maxillary shelves. For vertical procedure in the In the jaws, we can carry out bilateral segmental split osteotomy, which is help the vertical malclusion, skeletal malclusion, or we can carry out a fourth one to impact the maxilla, or to sit down the mandible or the maxilla down for vertical problems with subapical osteotomy. Or you can carry out combination of them, A and B. Let us let's see this view for the patient. Here we have increase over jet. So we are going to advance the mandible by which we call it bilateral sagittal split osteotomy. We have class 3 here, in which we have advanced mandible. So we are going to carry out bilateral sagittal split osteotomy to take the mandible back, which is unstable. This procedure is unstable unless we are going to go for rigid fixation. Here we have vertical problem. So in which we are going to intrude the maxilla. We are going to do some sort of maxillary impaction. So we are going to solve the vertical problem for this case. So this is some sort of operation. Some patients are going to carry out some sort of maxillofacial destruction osteogenesis. But if we are going to consider this versus orthognathic surgery is more stable in the future. So, but sometimes you should carry out this type of treatment, which is destruction osteogenesis, for some sort of psychosocial problem for the parents as well as for the kids. Cosmetic surgery to improve the aesthetic involves the nose, rhinoplasty, and the chin, genioplasty, which is very stable. And we're going to carry out some sort of soft tissue psychometric analysis for this, very important. Sometimes we are helping in treating some other problem like sleep apnea hypopnea syndrome. Just we are going to help by which we call it sleep apnea mouse guard. Here we have a restricted mandible and restricted airway. So whenever you have retruded mandible like this, it is better to advance the mandible, or it is better to take the mandible counterclockwise. So avoiding taking the mandible or moving the mandible clockwise rotation. So whenever you are going to, if possible, whenever you are going to take the mandible forward, this will help increasing the air flow and increasing the respiratory angle. So we have which we call it sleep apnea mouse guard. This is easy. You can do it in the lab. Also, we are helping in the TMJ problems, but we are not treating TMJ according to the HAL. So the most common anomalies that we are facing, and we're sharing the treatment with other team consultants, cleft patient, very common. Cleft lip and palate, they are the most commonly seen congenital deformities that occur at the time of birth. One in every 700 cleft lip and palate, and one in every 2,000 cleft palate in the UK. And nowadays, the cleft palate is more prevalent. So for the undergraduates, you need to know this information by heart. Problem associated with cleft, dental problems, aesthetic problems, psychological problem, speech problem, hearing problem. So it is a very important topic. Dental problem associated with clefts, congenital missing teeth. We have a lot of congenital missing teeth, hypotonisia, anotontia, oligodontia, presence of natal or neonatal teeth, presence of superior teeth, which lead to a lot of problems, and ectopic erupting teeth, anomalies of teeth morphology, big shaped lateral, and something like that. Enamel hypoplasia, and we have microdontia, fused teeth, abrasion in crown shape, macrodontia, mobile and early shedding teeth, posterior crossbite, because sometimes the tongue is down, so the cheek will compress the upper posterior teeth and that lead to posterior bilateral posterior crossbite, and sometimes deep bite. Protruding premaxilla, very common associated with cleft. Spacing and crowding, sometimes. And sometimes we carry out some sort of aesthetics can result in a lot of facial information like the nose, hearing, and speech. Cleft usually associated with middle ear disorders. So cleft is a very important issue. Psychological problem, attraction, curiosity, pity, staring, find problem in obtaining jobs, making friends. So in management, we have to have number of healthcare practitioners, number of professors, number of consultants, number of specialists, number of nurses. So we need some sort of teamwork. Oral maxillofacial surgeon, very important, orthodontist, pedodontist, pediatrician, prosthodontist, social worker, genetic scientist, ENT surgeon, plastic surgeon, psychiatrist, cleft nurse, and speech pathologist. So it is a team work. For cleft patient, we have in orthodontic department, we have 4 stages of treatment. First, we're going to carry out the pre-surgical operation obturator for the patient, and sometimes we use a steel strap to facilitate the surgery for the surgeon, and this is the first stage. And the second stage, we are going to carry out some sort of modification for the obturator after 18 months. And we are going to carry out some sort of restoration if there is some sort of caries, some sort of oral hygiene control. And this is the second stage. In the third stage, we are going to carry out some sort of expansion for the maxilla from age 6 years old up to 11. We are used to carry out some sort of expansion for the maxilla. The most common device that we use is quad helix for expansion of the maxilla for cleft patient at that time. And sometimes we need to go for some sort of rapid expansion by hygienic rapid expander, which we call it Hyrex. And after that, in stage 4, we use some sort of fixed appliance for comprehensive treatment from age 12 years old up to 18 years old and above. So we have 4 stages in our orthodontic department for cleft patient. We are sharing this team. Let us discuss some sort of cases in orthodontic surgery. Case presentation number 1. This is my first case in my life. I started doing this 2011. So I'm going to apologize for some sort of good photos because I was just a trainee at that time. Patient MM, she was 28 years old at that time. Her chief complaint, my upper front teeth sticking out. Her overjet at that time was 11 millimeters. After comprehensive investigation, as well as diagnosis, as well as X-rays analysis, photo analysis, cast or model analysis. So we have retreatment facial photos, and we have frank-form mandibular vein increase in this case. We have gummy smile for her. profile was convex. So after comprehensive analysis for her, lip incompetent, decreased nasolabial angle, pre-treatment dental photos, front, right side, left side, upper, as well as the lower jaw photos. Panoramic X-ray for her, comprehensive hard tissue cephalometric analysis for her, digital one, and we carry out a lot of angle. The most important for the team to discuss is SNA, SNP, ANB, maxillomandibular bone angle, lower facial height, total facial height, upper incisor posterior plane, lower incisor mandibular plane, and interincisor angle, soft tissue angle, nasolabial angle. This is very important for the surgery to carry out. We, uh, we carry out a lot of analysis for the patient comprehensively, hard tissue analysis as well as soft tissue analysis. So for this case, we have A and B is 10. So we should carry out some sort of orthodontic surgery for this case. Whenever you have A and B more than 9, you should carry out some sort of orthodontic surgery for the case. Because whenever you're going to do for orthodontic treatment only, the relapse will be very high, and sometimes we're going to worsen the case. So in orthodontic surgery cases, we have to go for comprehensive analysis, soft tissue, dental tissue analysis, as well as hard tissue analysis in the bone, as well as in this. Prepared for surgery, as you know, first we're going to decompensate the case. We're going to correct the relationship between the teeth as well as the bone. And this, by this way, we're going to worsen the case before surgery. And you have to tell the patient. We used to use at that time, which we call it semi-adjustable articulator, and nowadays everything is changed for better. Overjet became 14 millimeter before surgery. It was 11. So whenever you're going to compensate, you are going to worsen the case, and you should tell this for the patient for the starting time. So now we correct the relationship between the teeth and the bone, but the relationship between the two jaws is worsening now. So we have a huge gap here between the upper and lower jaw, 14 millimeters. And then we carry out the orthodontic surgery after preparing the everything for surgery, paralleling the root as well as preparation the orthotomy line for the area for the surgeon, and we read the rigid wire here, which is 1925 stainless steel, and we did some sort of decompensation, leveling and alignment and everything before surgery. Then we carried out the surgery for the patient. I will just show some part of the operation, which we carried out the pre-maxillary surgery at that time. This is, it was like 2011 or 2012, as well as I remember. So here we used to put the correct occlusion inside the theater in a proper way. Before leaving the theater, we have to make sure everything is correct. And we have to take care about the condyle position while we are doing this procedure. So to avoid relapse, to avoid some sort of idiopathic problem, to avoid some sort of hidden problems, you have to make sure you are in the right surgical procedure by using your surgical splint or whatever. And this is progress photo after 2 months after surgery. So this is which we call it post operative orthodontics or post-surgical orthodontics. You have to carry out some sort of detailing of occlusion. You have to put some sort of elastics. You have to make sure everything is going in the right direction. And here the healing of the surgical procedure and everything is settled now. It, this is a post surgical photo for the patient. This is intraoral photos, and this is after surgical as well as orthodontic treatment. And now our occlusion is class 1. Everything is class 1 inside the relationship, canine relationship, molar, a little bit in class 2, which is full unit class 2, which is stable for us. This is pre, and this is post after treatment. And this is after treatment. This is her face and her smile before the treatment. And this is her profile before the treatment. This is her profile after the treatment. So the patient was very satisfied at that time. And this is her first day. She's asking me, what are you going to do for me and for my case? And this is her smile after doing her surgery. Second patient, in which you have class 2, division 1, 12 millimeter overjet, complete overbite, or which we call it complete debite, vertical problem as well as anterior posterior problem for this case. We didn't see her lower teeth at all. Her X-ray, class 2, division 1, complete deep bites. We carried out pre-surgical orthodontics, leveling alignment and everything. Two days after orthodontic surgery, you have to tell the patient there is some sort of swelling due to surgical procedure, as well as due to some sort of drugs you're going to use during surgery. So, apologize. Sorry. Steroids lead to some sort of swelling sometimes for the patient. After osmosis surgery, this is a plate and OPG. We have to make sure everything is settled. This is her profile after surgery, and this is her smile before surgery. This is her front view before after surgery. This is her smile before surgery. This is her smile after surgery. This is her lateral view before surgery, and this is her profile after surgery. This is her teeth after surgery, in which we correct the vertical problem in a proper way. So this is the case before surgery, and this is the case after surgery. So whenever you have vertical problems due to skeletal etiological factor, go for some sort of orthodontic surgery. And she came to me and she mentioned that I'm very happy at that time. Third case, in which we have two jaw problem. This patient coming with some sort of long face, incompetent lip, class 2 division 1, increase over jet, increase vertical relationship. We have a lot of problem. Posterior, vertical, soft tissue problem, and everything. This is a case before, anterior open bites, class 2 division 1, increase over jet, missing some teeth. So we have to do something for her. We start our treatment first with orthodontic therapy. She came to me after a while, and there is some sort of uncontrolled hygiene, and I talked to her more than she brought her oral hygiene later on. We create some sort of surgical straightening line. We have to prepare something for this before surgery. And we carried out, which we call it VTO or visual treatment objective for the patient, in which we are going to carry some sort of analysis for the cephalometric to do some sort of movement before surgery, and to imagine what is going on after surgery, or what is the result after that. So we have to go for, which we call it VTO analysis first. And this is a part from the surgical procedure. For this case, we carry out double jaw surgery. Listen. This is the waiver. That is the waiver. The guideline for us, the guidance for us. This is our street. This left. هو يقول عمل له فيتاليزيشن للاسنان هو في البين فورورد انا خلاص كده كده خلاص ساتسفايد ساتسفايد كنت رجعت So, Profizi, one of my distinguished professors who teach me a lot, as well as we carried out a lot of operation together, as well as his Professor Suleiman, another professor in surgery. This is the maxillary surgery. And this is the mandibular surgery for this case. This is 6 months after surgery. After orthodontic surgery, settling of occlusion with intermaxillary elastics is very important. Minimally, it should be for 3 months. And this is the patient 7 months after surgery. We continue our orthodontic treatment after orthodontic surgery, still maintaining some sort of occlusion for her. And this is her pre-cephalometric view after surgery. This is her mandible after surgery. And this is her occlusion after surgery. So this is her profile and front view after surgery. She came like this, and she finished her treatment like this. Even her mom, she didn't recognize her at that. She was very pleased at that time, and she get married after the surgery, after a while, after some treatment, and she used to thanks a lot, thanks us a lot more than one time. Our family called us more than one time. This is third case of or fourth case of our surgery in which we have class 3. So we have to have some sort of class 3 in this presentation. We used to use semi-adjustable articulators, but nowadays, or years ago, we changed from semi-adjustable to fully adjustable articulator. This one, this will give you accurate mock surgery and accurate transfer of the reading from the patient to the articulator. So now we have this. This is a patient pre-surgical, pre-orthodontic problem, pre-photos intraoral, in which you have class 3 spacing. The maxilla is completely engulfed by the mandible, and there is no occlusion. She has some sort of problem in eating, some sort of problem in everything. This is her extraoral photo before surgery, in which you have concave profile here. So we carried out double jaw surgery for this patient, me and Profezi together. Profezi was the leader, and he did very nice work. We carry out some sort of level 1 for the maxilla. And whenever we have double jaw surgery, we are going to start with the fixed bone, which is the maxilla. And then we are going to carry out, we have to have some sort of intermediate waiver or intermediate spleen for the maxillary surgery. Then we are going to carry out the mandibular surgery, and we're going to fix it with the final waiver or final spleen for the case. So this is done in the mock surgery before this surgery. So we carry out some sort of level 1 for the maxilla, be advanced, and some sort of be bilateral sagittal split or something for the mandible. And this is her profile after surgery. So huge change. This is her intraoral photo before surgery and before orthodontic treatment, and this is her intraoral photo after orthodontic as well as orthodontic surgery. So huge change for her. This is her profile before treatment, and this is her profile after treatment. So my message for my colleagues, you have to avoid doing some sort of orthodontic treatment alone for asymmetric face, as well as for poor soft tissue morphology, more particularly for syndromic patients. And you have to avoid doing some sort of orthodontic treatment alone for long faces patients. So we have to determine this, what is long face, and when we are going to do surgery for the case, whenever we have the total facial height for the patient is more than 125 millimeters, so which we call it long face syndrome. You have to avoid doing some sort of orthodontic treatment alone for skeletal anterior open bite. Whenever you have skeletal anterior open bite, it is unstable. If you are going to carry out just orthodontic treatment, or if you are going to carry out orthodontic treatment with one jaw surgery, still there is instability. So whenever you have skeletal anterior open bite, you have to carry out orthodontic treatment first. Then you are going to carry out double jaw surgery for this case, and then you have to carry out some sort of post-operative orthodontic again. Whenever we have moderate to severe cases and posterior discrepancy, in which we have the ALP angle more than 9 or less than -3. Like if we have class 3 with an ANP angle -4, -5, -6, -9, -10, we have to carry surgery for this case. Whenever we have ANP angle like for class 2 more than 10 degree, we have to carry out of some sort of orthodontic surgery for the patient. Otherwise, we are going to move the teeth and we are going to leave the bone outside. And this is unstable, we are going to worsen the case more. So whenever you have or get more than 10 millimeters in non-growing patients, because if you have growing patients, we are going to do some sort of gross modification, as well as if we have severely profiling teeth and there is spacing, we are going to close the space and we are going to decrease the overjet. So whenever we have overjet more than 10 millimeters in non-growing patients, this is very important for us. You have to avoid doing some sort of orthodontic treatment at all. Whenever we have long face, the facial height is more than 125 millimeters, you have to go for orthodontic surgery first, then orthodontic surgery, and then post-surgical orthodontics. So this is very important slide for us. The post-surgical orthodontics and stability, the hierarchy of the stability and predictability of the cases. We have very stable procedures like the maxilla. Whenever you're going to impact the maxilla, this is very stable. And nowadays with rigid fixation, this is very stable. Whenever you're going to advance the mandibular forward movement, this is stable. Whenever you're going to move the chin any direction, this is very stable. Stable, but not very stable, maxilla forwards in class 3 more particularly. Maxilla, any asymmetry in any direction, it will be stable, but not very stable. But nowadays with rigid fixation, this will help. With plates. So stable with rigid fixation only, maxilla up. Whenever we're going to impact the maxilla, whenever we're going to taking the mandible forward, or whenever we're going to forward the maxilla with mandibular setback. Although mandibular setback is unstable, problematic sometimes, and problematic with more particularly with sleep apnea patients. So it will lead to some sort of respiratory problem by decreasing the nasal flow and the respiratory flow as well as respiratory angle. So as we have mentioned earlier, avoiding taking the mandible back as possible as you can. So maxilla forward with mandible backward with rigid fixation, it will be stable. Mandibular asymmetry with rigid fixation with plates, it will be stable. Problematic cases if we are going to carry out the mandible retraction or mandibular back. Whenever we are going to take the maxilla down, this is again is the muscle of mastication. Mastication, this which will lead to some sort of relapse. So try to avoid this if possible. Maxilla, widening the maxilla by surgery, problematic because the relapse is very high. So sometimes we have to go for some sort of overcorrection. I'm going to thank my professors who teach me a lot. In surgery as well as orthodontic surgery, more particularly, we carried out a lot of surgical cases with Prof. Ahmed, Suleiman, under general anesthesia as well as under local anesthesia for some sort of exposure. We carried a lot of cases together, and I was delighted for him. I'm delighted working with him. I'm going to thank him very well. My professor Muhammad Burhab Hizi, we carried a lot of cases together, more particularly class 2 cases, premaxillary surgery, reduction genoplasty, sliding genoplasty, and we carried out a lot of cases. We used to do more cases together. and we shared everything together. He taught me a lot. Here, some sort of discussion inside the theater. Uh, my teacher, Professor Kamal Abbas, Professor Mursi, Mursi, and Professor Malcolm Harris. Uh, he was the head department in King's College London, and this is a man who first course we carried out in orthopedic surgery. I carried out with Professor Harris. He wrote a lot of books, and he shared a lot of chapters in a lot of books. Professor Harris. Malcolm Harris, he's distinguished professor in surgery, obstetric surgery. Also, Professor Osama Levine, he teach me a lot, and we share a lot of discussion regarding surgical procedure as well as obturator for surgical patient, and when to carry out some sort of interim obturator or final obturator, intermediate obturator, when we're going to carry out some sort of cases. We discussed a lot of together. Also, Professor Jerry Kane, we discussed a lot of cases with him, and more particularly, I discussed a lot of diagnosis with him, more in radiographs. We discussed a lot of how to diagnose the cases in radiographs in a proper way, and he shared me and teach me a lot of knowledge. This is the staff of the Royal College of Surgeons. Sometimes we used to discuss our cases even in the exam diet. I used to utilize every time with them to discuss my cases with them. Professor Homara, we used to discuss a lot of cases with him. I'm going to thank my professor in orthodontic department as well as discipline, Professor Haider Abdullah Hashim, Professor Adil Maged, my distinguished teacher, Professor Muhammad Abul Qasim. He teaches me undergraduate as well as in postgraduate. My mom, as well as my professor, Mal Abu, she teach me a lot. In the department, his former head department in orthodontic in the Faculty of Dentistry, University of Khartoum. Professor Sheza, Dr. Abdul Bagi, he is distinguished in the orthodontic surgery, and he teaches me a lot. Dr. Fayyad, my young brother, he helped me a lot. Here, some sort of discussion in the departments, in our department, me and Dr. Adil Maged, Dr. Abdul Bagi, and this is our department staff. And this is Professor Dieter. I used to discuss a lot of cases with him during the exam dates. And this is RCS staff. Also, we used to discuss a lot of them with them. Kara, Professor John Walsh, John Sheridan, Professor Albert, Professor Dr. Abbas, and Prof. We discuss a lot with Dr. Abbas in the anatomical side. Whenever we have some sort of anatomical problem in the cases, I used to discuss with Prof. Abbas. So thank for your attendance, for your the attention during this lecture. Thank you.
Thank you, Doctor, for this valuable information. Now, guys, we are opening the floor for questions, and we will begin with the questions submitted through the form. But if you have any questions, please write them in the in call message or raise your hand and turn on your mic.
يعطيك العافية دكتور. تسلم الله يسعدك دكتور قمر.
الله يسلمك دكتور.
Before the questions, I would like to thank Dr. Gamar regarding this very fruitful lecture, and really we are happy that you are refreshing our memory regarding the orthognathic surgical procedures, and it is very difficult actually part in either ortho department or surgical department, but with that challenge you lead the others regarding that. So we are thankful to you again, and really we are happy with this presentation. Thank you very much.
Thank you, Dr. Hashim Khalid Mohammed Said, the head department of orthodontic as well as the special orthopedics at Rivat University. Thank you for sharing your information.
Thank you, doctors. Okay, our first question is, which is the best age for the orthognathic surgery for both maxilla and mandible?
Very difficult question, but I will try to answer it. We used to carry out the surgery after 18 years old. Okay, so but sometimes, more particularly the American school, they have mentioned they can carry out the maxillary surgery a little bit earlier. From 16 years old, they can carry out the maxillary surgery. But we used to carry out the surgical procedure after 18 years old. Because nowadays we used to do some sort of maxillary advancement by which we call it reverse head gear from 8 years old up to 10, and we used to do some sort of expansion for the medulla before 15 years old, and we used to do some sort of expansion after 15 years old, by which we call it MARBI nowadays. We start with temporary current devices.
Okay, there's Dr. Bassam raised his hand. Go ahead, Dr. Bassam, please.
Welcome, Dr. Bassam.
Dr. Bassam, do you hear us? Okay, I will read the second question and go back to Dr. Bassam again.
Dr. Bassam, he is one of
السلام
the.
عليكم.
Welcome, Dr. Bassam. He is one of the professor of surgery, surgery in Yemen.
Thank you, Samar, for this very nice presentation and lot of case presentation. But in the بداية موضوع الرامس osteotomy. Rams osteotomy can be used just for asymmetry or mandibular setback. It cannot be used for mandibular advancement or severe advancement for we prefer to use sagittal septate osteotomy. Just this notice. Thank you so much, Dr. Kamal.
Thank you, Professor Bassam. And we used to discuss, Professor Bassam, he's one of the distinguished maxillary surgeons in Yemen, and we used to discuss a lot of cases together. Thank you for your very nice information. Thank you a lot. I do agree with you, totally.
Okay, our second question is the best ortho-surgical approach for orofacial clefts.
The best also approach for or facial cleft, you have to
Yes.
start from 0 day. You have to join the team. we have to have team for patient, we have to have center for patient, and we have to join the team from the starting, from the day of birth. If there is some sort of intervention we're going to carry out to help, we are going to help. Even by very simple procedure, we're going to do some sort of steel strap to uh, to facilitate the surgery for the surgery later on. We're going to take the prima maxilla close to the heart valve. And sometimes we can use some sort of obturator for the cases.
Okay, there's Dr. Rufaida. Please, Dr. Rufaida, open your mic and go ahead.
Assalamu alaikum. Thank you, Dr. Gamar, for very interesting and informative presentation. I would like to ask about the use of MARBI. Do you think using of MARBI and this assisted, implant reduce the need for surgically assisted rapid maxillary expansion?
Thank you for your very nice question, assistant professor and senior consultant, Dr. Rufaida Siddiq, the Department of Orthodontic and Interventional Orthopedics at Nilan University. Yes, nowadays we decreased going for surgical assisted bilateral expansion by using MARPI after thorough investigation, as well as doing some sort of CBCT for the patient, and knowing the depths of the palatal bone, in which we are going to put our temporary device inside the expansion appliance. So we used to do some sort of 4 temporary anchoring device, size 8, size 10, and sometimes we can use size 11 even. So for this, we used to do it without going for the theater, and this reducing the need for some sort of orthodontic surgery for narrow cases. Thank you, Dr. Orfay.
Thank you, Dr. Rufaida, for joining us today. Okay, our next question is how to identify cases needing combined surgical and orthodontic management, and how to plan treatment effectively between both fields.
We used to do some sort of joint clinic as a team. In our Faculty of Dentistry, University of Khartoum, we used to do the joint clinic every month on Wednesday. The first Wednesday in the month, we used to do our joint clinic with the surgical department, and we used to share our knowledge together. We used to do some sort of presentation to the case, and we used to discuss the case together. So at that time, we're going to reach the final diagnosis for the patient together, and we're going to put the treatment plan together. And sometimes we need some sort of other discipline to share us, like the perio department, as well as orthodontic department, and some sort of conservative treatment from the restorative department. And we used to discuss everything together. And sometimes we need to negotiate some issues with plastic surgeon as well as with ENT surgeon together. And this is the right way to sit together and as a team and to read the final diagnosis for the patient. And then we're going to start our treatment plan.
Okay. Study surgery or ortho to be an orthognathic surgeon.
You have to study both of them. If you are going to go, if you are going to go for surgery, you can just concentrate on orthodontic surgery cases to be like some sort of subspecialty for you, and then you are going to carry out the orthodontic surgery with other team. If you are going to go for ortho, you have to concentrate on orthodontic surgery cases during your training and after your training, and then you are going to make it easier for you to join the team of orthodontic surgery. So orthodontic surgery is a team. There is no specialty just which we call it orthodontic surgery. It's a teamwork. It's a teamwork. So we have to always we have to do it in a teamwork. Thank you for your question.
Okay. I hope he or she found his answer. Okay. Um, how doctor you management of unexpected events during surgical procedure?
For orthodontic surgery, we used to do our thorough investigation first, and we used to do some sort which we call it mock surgery before the surgical procedure, before going to the theater together. And then whenever we are going to go to theater, we are going to minimize the risk to the minimal levels. During my 12 years, past 12 years, experiencing orthodontic surgery with surgical staff, we have no communication, alhamdulillah, till now. So whenever you are going to go for surgery, go for thorough investigation, proper investigation, all the analysis you have to carry it in a proper way. If you have any doubt, return back and discuss with the team. Never ever go to a theater without guaranteeing everything before doing the theater. Whenever you are going to face during surgery, you have to have some sort of experience to deal with it. He's a professor in surgery, and alhamdulillah, there is no problem facing us till now.
Alhamdulillah. Um, okay. Yeah, doctor, it look like your kids are joining us to support you.
Yes,
That's so sweet, حقيقة.
I used to ask them as a kids after doing surgical procedure for a patient. I used to show them the photos for the patient before and after the surgery, and they used to mention to me, this patient is older than this. So regarding the pre-orthodontic treatment, they show the patient like old, and after surgical treatment, they show because they are kids, they're not give you the uh, very well opinion without bias. So always I keep saying this is older than this, but I have to mention for them this is older than this. The after surgery is older than before surgery, but she looked more younger. Thank you, Victoria, for sharing this idea.
Wallahi, we are really happy to have them here
Thank you.
for real and send them our love and regards.
Thank you.
Okay,
Thank you a lot.
to continue our questions, how to handle complex surgical cases, I think.
How to handle complex surgical problem like double jaw surgery with vertical problem. Whenever you have anterior posterior as well as vertical problem as well as transverse problem, this is some sort of complexity for you. So in this case, you have to sit down more than one time. You have to investigate a lot. You have to do some sort of X-rays, uh, cephalometric, OPG, CBCT. You have to do some sort of thorough reading for the X-ray and analysis, soft tissue analysis, hard tissue analysis, dental analysis, and you have to go for cost analysis, and you have to go for photo analysis. Then you are going to go for the team to discuss more than one time the case, and then you're going to set the final diagnosis for the case, and then you have to carry out the jaw surgery in this case to guarantee your stability. So whenever you have complexity, go for double jaw surgery, plus or minus chin surgery, uniplasty, sliding or reduction by uniplasty.
Okay, let's go to the questions in the in call message. Um, Rian, okay. Samah asked that who is the first specialty to diagnose the need for surgical orthodontics?
Teamwork. There is no fake one.
Um,
It is a teamwork. Yes, as orthodontists, we used to see the patient because he will come to the orthodontic clinic, but we have to do it in teamwork. There is no one that is first. We are a team, and this is a success. Whenever you're going for team, you're going to succeed in your case. Whenever you're going to do it alone, you're going to do some sort of complication for your case. So there is no one is first.
okay. Um, Dr. Mohammed Abdu said brief about the visual planning of orthognathic surgery.
You are afraid from the virtual from VTO. We used to do VTO for two surgical problems. Whenever we have anterior posterior as well as vertical problem, but whenever we are going to go for three-dimensional surgery, we are going to do some sort of which we call it surgical treatment objective treatment plan. So VSTO, systematic surgical treatment plan for the patient in three-dimensional. We are going to go for mock surgery. We are going to go for some sort of doing surgery in the model. We are going to create model for the patient with the CBCT X-ray. We are going to do it in the CAD/CAM system. And so whenever we have complex cases, we have to go for thorough analysis, more investigation, more X-rays like CBCT, but you don't need to go for every case for all this. If, for example, if I have pre-maxillary surgery only, I don't need all this. But if I'm going to go for double jaw surgery, plus or minus genioplasty, Lefort 1 bilateral sagittal split osteotomy, as well as a reduction or sliding genioplasty, and I have some sort of anterior problem, anterior posterior, as well as vertical, as well as transverse problem, I have to go for thorough analysis. So VTO, it will never be enough for you at that time. You have to go for further systematic analysis.
Okay. Dr. Rian Amir, every orthognathic surgery, we need maxillofacial surgeon plus orthodontist at the theater. I think we repeat the question.
Absolutely, it is a teamwork. You need them. It is a teamwork.
Okay, Dr. Samah Tawil said how many months are needed for recovery, or what is the process of recovery after an orthognathic surgery?
Me with Prof. Hizi we used to do the theater, the operation on, for example, say on Saturday, and he used to visit me and him. We used to visit the patient every now and then. So Saturday, Friday, Saturday, Sunday, Monday, he will write down for the patient to leave the hospital. This according to Prof. Hizi. He used to do so. So like 4 to 5 days, because already we have some sort of rigid fixation, surgical treatment very, in a very proper way, and everything is settled. Whenever we are going to make sure everything is settled, Prof. Hizi used to do some sort of discharge for the patient.
Okay, Dr. Salah Taha asked, can Invisalign be effectively used in the pre and post orthodontic phases of orthognathic surgery, or are fixed appliance still preferred?
For my experience point of view, I like doing some sort of fixed braces for orthodontic surgery because I need some sort of bodily tooth movement in a proper way. I have to have some sort of better and proper fixed appliance type from better company worldwide. I don't like doing some sort of Invisalign or some sort of clear pass orthodontics for surgical cases. So I heard some orthodontists doing so, but I don't like this way at all. Uh, in my experience, I used to do for every orthodontic surgery, I have to guarantee my work with fixed orthodontic appliance to guarantee my movement, all the type of movement with fixed appliance. But I have some sort of uh, discussion for the Invisalign as well as which we call it the clear pass orthodontics in general for all the type of movement. Sometimes I cannot carry out all the type of movement with clear pass orthodontics. I use it. I used to use this with mild to moderate cases. So I do agree using clear pass orthodontics for mild to moderate cases, but for severe cases, I have to go for fixed orthodontic appliance to guarantee my work.
Okay. I think Dr. Bassam raised his hand. Dr. Bassam, please open your mic and go ahead.
Prof. Bassam, you're welcome.
Okay,
دكتور
sorry,
قمر،
Prof.
شكرا
Bassam.
جزيلا، شكرا جزيلا لكم. بصراحة أحب أشكرك على ملاحظة قليل ما نرى أخصائي الأورثودنتيك أو الاستشاريين يتكلموا عليها. أنت في المحاضرة جبت إنه أفويد كاموفلاج، وجبت الحالات اللي نتجنب فيها الكاموفلاج. قليل من الناس اللي يتكلموا على هذا الشيء أو ينبهوا له، لأنه أنا في اليمن مثلا أكبر مشكلة بنعاني منها كجراحين وجه وفكين أو أورثوجناثيس هي مشكلة إيش؟ الكامفلاج أو البري سيرجيكال تريتمنت. كثير من الناس بيشخصوا الحالات وبيعالجوها أورثودنتيك، يوصلوا إلى طريق مسدود، ما بيقدروا يتعاملوا مع الحالات خالص، بعدها بيبعثوها لنا. احنا بنعاني مشكلة كبيرة جدا جدا جدا. فاللي بيساعدنا فيها الفيرتشوال سيرجيكال بلاننج. فالموك سيرجري ما بتنفع بهكذا حالات. فأحب أن أشكرك، وهذا دليل أنك بتفهم في الأورثودونتيك وفي الجراحة، أنك فاهم عن إيش الجراحة، ولذلك نبهت لهذا الشيء. الكاموفلاج أكبر مشكلة نعاني منها إحنا كجراحين. شكرا دكتور.
Shukran, Professor Bassam, for your nice information, valuable information, as well as your knowledge. Professor Bassam is distinguished mouth surgeon, and he used to do orthodontic surgery years ago. He faced a lot of problem in cases of camouflage. As I have mentioned before, don't go for camouflage if you have severe cases like A and B more than 10, A and B less than -3, like -4 and 5. Don't play with this case. Just go for orthodontic surgery. First start with ortho therapy, then go for surgery, and then go for post-operative orthodontic. So there is no way to play with cases like these cases, like a long face, more than 125, overjet more than 10 in non-growing patient. If we have skeletal anterior open bite, so cases like this, don't play with them. From the starting time, you have to tell the patient and the family, this case, it will go for necessary surgery definitely, or otherwise we're going to worsen the case. So we're not going to do just orthodontic treatment, because orthodontic treatment, just we carry out, we are going to carry out the orthodontic treatment for teeth as well as the alveolar bone around. For the basal bone, no. Thank you, Professor.
Thank you, Prof. Bassam. And there is Fatima Hassan. She said, thank you, Professor, for your very useful information and cases. Her question is, she said, I have a patient with jump smile due to vertical maxillary axis hyperactive and short upper lip, skeletal class 2, dental class 1 molar and canine. Does we will need double jaw surgery or just lift one maxillary impaction is enough?
She have mentioned the anterior posterior problem, but she didn't mention the vertical as well as the transverse problem. If she had some sort of vertical problem like skeletal open bite or deep bite, in this case, definitely you are going to go for the jaw surgery. But if you have just only anterior posterior problem, like you have mentioned, only one jaw surgery sometimes it will help. It depends on your analysis. It depends on your thorough investigation. It depends on the case profile. It depends on the X-rays. So if you have transverse problem, bilateral posterior skeletal crossbite or bilateral skeletal neuromaxilla. So it depends on the other analysis. But as you have mentioned, you have only anterior posterior problem. In this case, you can carry out sometimes you can carry out one jaw surgery. So it depends. You can send the case for us. We're going to do some sort of analysis for her. I'm going to share you the information together.
Okay, Dr. Duha Maruf, she said, is it better to start growth modification early in a growing patient with a severe skeletal problem as class 3 with open bite, or to wait and proceed with surgery later?
Thank you, Dr. Duha Maruf. She is one of our distinguished candidates. And now she's doing her postgraduate in orthodontic as well as orthodontic surgery as well as interventional orthopedics. Thank you for a very nice question. Whenever you have very severe case, even class 3 or class 2, whatever, very severe cases, and we have analysis for this, you have to tell the patient from the starting time, even if the patient is 6 years old, you have to tell the family she will go for orthodontic surgery later on, whenever you have very severe case. But if you have mild to moderate cases, for example, for class 3, and she came like 8 years old, we are going to carry out some sort of gross modification by reverse headgear. The most updated one is which we call it the real type. It was mask of Dolaire previous years ago, but now they call it real type, which allows the patient to sleep well. So we are going to carry out some sort of advancement from age 8 to 10 years for the maxilla. This problem is related to the maxilla. So in this case, we can modify the gross. If the case is related to the mandible, you can carry out some sort of gross modification by functional lines for boys from 12 to 14 years, and for girls from 11 to 13 years old. So it depends on the jaw, it depends on the case. Is it so very severe? You have to tell the patient, family from the starting time, she will go for orthodontic surgery, she will go for orthodontic surgery later on.
Okay, Dr. Fatima Al-Hassan, um, um, she said normal overjet, deep bite, and normal transfers. I think she mentioned her question
Yes,
of vertical.
Dr. Fatima, if the normal vertical relationship, which we call it vertical relationship, and normal transverse relationship, so sometimes we can carry out some sort of one-jaw surgery. In this case.
Okay, last but not least, we're with Dr. Ala Al-Hadi. She said, what are the objectives for pre-orthognathic surgery orthodontics? It is for decompensation or for minimizing the severity of the case?
So objective for pre-surgical orthodontic, first of all, you have to do some sort of decompensation. This is very important, decompensation first. Then you have to go for alignment and leveling and harmony of the arches with their teeth. Then you have to do some sort of leveling and alignment for the teeth, and you have to reach the rigid wire, which is 1925 stainless steel. Whenever you are going to reach this wire, now you are ready for surgery. And you have to create osteotomy line for the surgeon. Sometimes you need to go for some sort of pre-maxillary surgery, for example. You have to create a space between the roots, between the first premolar and second premolar, or sometimes between first premolar and the canine. So you have to create this surgical line or surgical area for the surgeon to do his operation in this area. Otherwise, don't hurry up for the operation. So the objective first, you have to decompensate. This is very important because seeing the patient in the chair is not enough. Uh, 50% of the cases, you are going to see the 50% of the severity of the case, you are going to see it in the chair. But you have to go for analysis, proper analysis, more particularly for X-rays, as well as photo, as well as model analysis. Then you're going to discover the other rest of the 50%. So you have to decompensate first. Then you have to do some sort of leveling and alignment. Then you have to create a space for the surgical line to do the surgery in this area by paralleling the root and taking the root away from this area. And you have to do to reach the rigid wire, which is 1925 stainless steel, and you have to do some sort of which we call it creamable hook in the past, but nowadays we used to use temporary devices for the surgical treatment cases. So this is the objective for the before surgical treatment. Very important, and you have to create your splint for the surgery. You have to create your splint. If you have double user, you have to do some sort of two splint or two waver, pre or intermediate waver, and then as well as the final waver for the surgery. Whenever you're going to prepare everything and to go for mock surgery first, this is objective of treatment before surgery. Thank you for a very nice question.
Okay, before I hand over the mic to my okay, if there are any question, if there is any questions, please raise your hand or okay, Khalid, please open your mic and
Good
go
evening,
ahead.
Doctor. I have a quick question regarding the cleft lip and palate, as it is a matter of conflict between ENTs and dentists. So, what's your take on that?
Whenever we have, as I have mentioned earlier, whenever we have cleft lip and palate, we have to go for cleft center. We have to go for the team, and we're going to put the treatment plan together. ENT surgeon, orthodontist, maxfac surgeon, pediatrician, pediatric endodontist, prosthodontist, social worker. We have a lot. We have like a speech therapist, speech consultant. We have like 11. So the ENT surgeon, they have main role in treating the cleft patients. So we used to do it in team together.
Is it clear for you, Khalid?
So Khalid.
Okay.
Dr. Khalid. Dr. Aya.
Okay, sorry. Um, Reem said, as a fourth year student, I have a question about multidisciplinary cases. If a patient needs orthodontics, orthognathic surgery, and dental implants, what is the best standard sequence to follow for these three procedures?
Very nice question. Whenever you have to go, whenever you have case like this, in which you are going to carry out some sort of orthodontic treatment as well as orthodontic surgery as well as implant, we have to start with orthodontic treatment first. Why for? Because we are going to do some sort of decompensation, leveling and alignment, and harmony of the faces, of the jaws together, and we have to create some sort of reed wire for the surgery, and we're going to create space for the surgical operation, and then we're going to do some sort of occlusion harmony for the case. So first you have to start as orthodontist, and then we're going to go for surgery for the case, and then after doing the surgical procedure, in which you have proper occlusion, skeletally as well as dentally, then we are going to go for implant as a final procedure for this case, in which we are going to guarantee the spaces is well distributed for the implant. We're going to guarantee the occlusion as well, and the contact in harmony. We have maximum interpassion between the upper and lower jaw as well as between the upper and lower teeth for this case. Then we're going to finish our case with very nice implant with implant consultant or with implant operator. So first orthodontic, then orthodontic surgery, then post-operative orthodontic, then implant. Thank you for a very nice question.
Thank you, Reem. Okay, is there anyone have a question? Okay. Before I hand over to my deputy, Isra, I just want to say we are truly grateful to all the attending doctors and professors, as well as Dr. Gamar, for his time and effort. Beyond that, we appreciate his support and interest in helping us produce beautiful and impactful work for everyone. We feel incredibly happy, grateful, and lucky, not just because Dr. Gamer, one of our university professors, but because there are educators with such a high level of dedication to science in our country. Thank you so much, Dr. Gamer. We really appreciate um, your joining us today.
Thank you, Dr. Aya Fatih. Thank you for your duty and for your members in the Faculty of Dentistry Student Association. And thank you for my professors who teach me a lot. Thank you for my colleagues. Thank you for my young generation in the Faculty of Dentistry staff. And thank you for all the undergraduate at Faculty of Dentistry University of Fort Home. And thank you for sharing our knowledge together, even professors with their candidates. They used to share knowledge together. I used to learn a lot from my candidate. I used to learn a lot from my students. And I used to learn a lot from my colleagues. So this is the right way. Whenever you are going to search for information, work for your colleagues, for your professors, for your students. I'm still learning from them. I'm going to continue learning from them. Thank you, our attendee from Yemen. Thank you for our attendee from Egypt, from Saudi Arabia. My colleagues in the Saudi Arabia, consultants and doctors. my colleagues from UK attending with us, our colleague from Ireland attending from us now. Thank you for all, and see you tomorrow with Professor Yusuf Osman Yusuf in the very rare case worldwide
Okay.
WTO with
Uh,
Professor Yusuf Osman Yusuf tomorrow, inshallah. Thank you for today.
Saru, the mic with you now. Thank you, Dr. Gamar.
Thank you, Aya, for that. Hello, everyone. And with this, we have reached the end of our webinar. We would like to extend our deepest appreciation to Dr. Gamar Ahmed Suleiman for the outstanding presentation and sharing his valuable knowledge. It was truly an insightful and enriching session. Thank
Thank,
you, Dr. Gamar, for your time and it's amazing session.
thank
And
you.
we would like to express our heartfelt thanks to all attendees from professors, doctors, graduate, and students. Your support and interaction made this webinar a great success. Also, I would like to thank our head Ilaf Mu'taz and her vice Rizam Mahmoud for their support and contributions in producing this work in its current form. Thank you again for all, and we are excited to see you tomorrow in our last session with Dr. Yusuf Osman Yusuf in Real Surgical Insight. مع
Thank you.
السلامة and good night.
Thank you. Thank you. Assalamu alaikum.